Thank you, Vijay, for a very kind introduction. Dr. Neglur and I go back, how many years? Almost 40 years or more, 46 years. We are friends for 46 years. The topic given to me is the Canvas program, Renal Outcomes Perspective. Now, excess morbidity and mortality in type 2 diabetes mellitus primarily results from cardiovascular or macrovascular disease. But kidney disease is ever increasing. If you see the earlier, say 20 years ago, kidney disease was not that important. People used to die of coronary artery disease. But now kidney disease is coming up in a big way. Why? Because diabetics are living longer. They're living long enough to develop kidney disease, and you can control the risk factors which can prevent the decline of kidney function. A good glycemic control can reduce the chances of microvascular complications. A good blood pressure control is very important. When there is albuminuria, specific treatment with drugs for albuminuria and specific inhibition of the renin-angiotensin-aldosterone system, like using an ACE or an ARB, can benefit. Let us look at the Canvas program. What are the design and the methods that they used? The Canvas had a 2-week placebo run-in, canagliflozin 300, 100 and placebo. And the Canvas R, which was to look at the renal outcomes, was a 2-week placebo run-in, Cana 100 and 300 versus a placebo. What are the inclusion criteria? Patients had to be type 2 diabetes, HbA1c more than 7, less than 10. eGFR had to be more than 30 ml, age above 30 years, but they should have a history of prior cardiovascular event, or age above 50 with at least 2 cardiovascular risk factors. So all the patients had a cardiovascular risk or event background. And what are the risk factors? Diabetes duration more than 10 years was considered as a risk factor. Systolic BP more than 140 and on more than one medication. If he's a current smoker and if he had a micro or macroalbuminemia and low HDL. So these were the inclusion criteria. What are the objectives of this study? The primary objective was cardiovascular death, non-fatal MI, or non-fatal stroke. And the secondary was all-cause mortality and cardiovascular death. But other exploratory things that could come out of this study was non-fatal MI, non-fatal stroke, hospitalization for heart failure or CV death, total hospitalizations, and what you see in yellow is basically related to the kidney. Albuminuria progression, albuminuria regression, renal composite, that is 40% reduction of eGFR, or end-stage renal disease or renal death. So enrollment, the Canvas, you had almost 4,000 plus, the Canvas R had 5,800, total 10,000. And if you look at the demographics of the Canvas study, look at the age, sex, duration of diabetes, hypertension, heart failure, NYHA classification 1 to 3, cardiovascular disease, the placebo group and the Cana group is practically comparable, no problem. Look at the demographics on race, whether they are Caucasians, Asians, Black African Americans or others, they are very much similar. Geographic locations are also very much similar. Baseline therapies, all these patients were obviously on some medications. If you look at the anti-hyperglycemic agents, metformin, insulin, sulfonylurea, DP4, GLP-1 agonist, very similar in both. Cardioprotective, RAS inhibitors, almost 80% of them had it. Statin, 75%. Antithrombotic, beta blockers, they're all very. So you have two groups which are very well matched and good. Look at the baseline risk factors. Both had very similar HbA1c, BMI, systolic blood pressure, diastolic, total cholesterol, HDL, LDL and triglycerides. What are the results of the Canvas study? Not the Canvas R, the Canvas. It showed a significant drop in HbA1c and the mean difference was about 0.58%. Systolic BP came down more in the canagliflozin group. The blue is Cana, the yellow is the placebo. It came down by about 4 millimeters of mercury, mean systolic pressure. The primary MACE outcome, cardiovascular death, non-fatal myocardial infarction or non-fatal stroke, that was for the placebo, and that's for Cana. Not much of a difference there, though the hazard ratio was just 0.86. But for non-inferiority, see, this trial was to see whether canagliflozin is inferior to placebo or it is superior to placebo. As far as non-inferiority, it is not inferior to a placebo, very significant p-value, but superiority not really convincingly shown. What are the effects on renal outcome? Now, renal outcomes, you had biomarker outcomes, which was change in albuminuria. You have renal intermediate outcomes, which was progression of albuminuria or regression of albuminuria. So, if a patient did not have albuminuria and develops albuminuria, that is progression. If the patient had a significant albuminuria and that regresses, that's a regression. And the composite renal outcomes confirmed and adjudicated. 40% decrease in the glomerular filtration rate, done on consecutive occasions, that yes, the eGFR has come down by more than 40%. End-stage renal disease or renal death. And how do you measure these outcomes? Albuminuria, to really look at microalbumin, correcting 24-hour samples and all is very tedious. A very simple test is to do the urinary albumin-creatinine ratio, which can be done on a spot urine. So the albuminuria was measured by doing the urinary albumin-creatinine ratio. The progression and regression of albuminuria, you looked at the change in albuminuria class, whether he had normal, he had a microalbuminuria or a macroalbuminuria, plus more than 30% change in the urinary albumin-creatinine ratio from the baseline. As far as 40% decrease in GFR is concerned, sustained more than 40% decrease in estimated eGFR was going into the 40% category. End-stage renal disease reaching dialysis or having a sustained eGFR less than 15 ml. And renal death due to a renal disease. So what are the baseline characters in the CANVAS-R study? They're similar between placebo and all. eGFR was very similar, 77-76. The median albumin-creatinine ratio was comparable. Use of ACE or ARB is almost the same. It is the same. Then there is a low renal risk population. In this group, if you see, there is a high percentage of normal eGFR and albuminuria in both the groups. Now let us look at what the renal outcomes were. Biomarker change in albuminuria, the percentage change in urinary albumin-creatinine ratio as per albuminuria class insert. If you see, this is normo, this is microalbuminuria, macro, all of them significantly reduce on Cana compared to the placebo, and the mean difference works out to about minus 18%. So that was the biomarker outcome for albuminuria. Renal intermediate outcomes, progression or regression of albuminuria. As far as progression of albuminuria is concerned, again this is your Cana and this is placebo. The progression is much less in the Cana group compared to the placebo group, and the hazard ratio is about 0.73. Regression means you have an existing level of albuminuria and that comes down. So that regression was much better again with Cana compared to the placebo. That was as far as the renal intermediate outcomes. The composite renal outcome confirmed and adjudicated. 40% decrease in glomerular filtration rate, end-stage renal disease, renal death. If you see, this is the placebo and the Cana. Basically, the events were very few. Out of 5,800 patients, you had only 21 who went into end-stage renal disease, and you had 239 patients who had an eGFR reduction. It's a very small number to really speak about. So the summary of the renal outcomes is that canagliflozin compared to placebo induced sustained lowering of albuminuria, prevented progression in albuminuria, induced regression in albuminuria and reduced renal function loss. There were less patients who went into end-stage renal disease. So these data suggest a potential renoprotective effect of canagliflozin treatment in patients with type 2 diabetes at high risk on top of those who are already receiving ACE and ARB. Because ACE and ARB are also supposed to be kidney friendly and can do all these things that have been shown here. So on top of a patient receiving ACE and ARB, Cana has shown benefits. This was a further analysis, additional analysis of renal outcomes of the CANVAS study, which was presented in the National Kidney Foundation in Austin, April 2018. Here they were to determine the effect of Cana in participants with eGFR more than 60 and an eGFR less than 60. They wanted to see whether there was any real difference. And if you look at the baseline characteristics, almost 80% of the patients in this group had a eGFR more than 60. Just 20% had an eGFR less than 60, and you can see the differences are there. But compared to the placebo, now if you see the blue is those patients who had an eGFR more than 60, green is those who had an eGFR less than 60. You look at the HbA1c, significant reduction, but more in the group where the eGFR was more than 60. For obvious reasons, as the kidney functions become less, the effect of the SGLT2 is also less. Systolic BP, relatively similar reduction. Body weight, more in this group with more than 60 eGFR here. But if you see the geometric mean of urinary albumin-creatinine ratio, there is a better improvement in those patients who had a eGFR less than 60, suggesting that probably this drug has some role in reversal of albuminuria. This is a placebo-subtracted differences in intermediate outcomes with Cana in participants with baseline more than 60, less than 60. Now, if you really see what happens here is, when you start, initially the eGFR in the Cana group falls. So compared with the placebo, Cana was associated with an acute decline in eGFR at weeks 6 to 13. So in the initial weeks, 6 to 13 weeks, there is a decline in the eGFR, and then it maintains itself through. But from 6 to 13 weeks to the last available measurement, you find that Cana stabilizes the kidney function and from the baseline, and it remains constant. So what happens here is, in the initial 6 to 13 weeks, there is a dip in the eGFR, and then it maintains itself throughout. And at the end of the study, in the Cana group, when discontinuation, 30 days after treatment was discontinued, they looked at the change from the baseline eGFR, and what do they find? That the eGFR increases. Once you stop the Cana, the eGFR increases and probably overshoots the original eGFR, suggesting that maybe use of Cana has improved the eGFR over a period of time, though during the time that Cana was there, it remains constant. So to summarize, the effect of Cana on the composite renal outcomes was large, particularly in patients with preserved kidney function, with evidence of benefit for eGFR more than 60 and less than 60. Results for major safety outcomes were consistent across both the eGFRs, and the effect in people with reduced kidney function will be more clearly defined when you look at the other studies, especially the credence which is going to come in the future. Now, this is with Cana. Is it true with the other SGLT2s? There are studies with EMPA. The EMPA-REG has also shown that there is a reduction in urinary albumin-creatinine ratio. DAPA also has shown that there is a reduction in urinary albumin-creatinine ratio. What is really the pathophysiology behind this? Do we know? Honestly, we don't know, but there are speculations. Let us look at those speculations. The issue of hyperfiltration. The pathophysiology of chronic kidney disease is complex, and many factors seem to contribute to its development and progression. One of the mechanisms that have been discussed as responsible for the damage to the glomerulus is hyperfiltration, which seems to be a compensatory phenomena occurring as a response to the nephron loss. So there is hyperfiltration. And hyperfiltration would in the long term damage the nephron and contribute to the progression of CKD. Now in a diabetic, there is increased reabsorption of glucose in the proximal tubule accompanied by increased sodium cotransport. Through the SGLT2 receptor, it goes in. This leads to a decreased solute load in the macula densa and to a consequent deactivation of the tubulo-glomerular feedback, which results in an increased GFR and hyperfiltration. This is what happens in a diabetic kidney. There is evidence that when you give SGLT2 inhibitors, they reduce renal hyperfiltration, probably by affecting the tubulo-glomerular feedback mechanism, because the sodium is also now being not absorbed. It comes there, and that is what activates the system there. So reduction of hyperfiltration could be responsible for the initial drop in GFR, which we have seen in these studies that in the 6 to 13 week, there is a drop in the eGFR. And this could be, so reduction in hyperfiltration would be responsible for the initial drop in eGFR observed at the beginning of the treatment with SGLT2 inhibitors and to the retarded decline of renal function observed when the medication was stopped. So when the medication was stopped, eGFR comes back. That could be the effect of the SGLT2. Now there are other factors which could be responsible, and the blood pressure reduction which is seen with SGLT2 has also been said that it probably has a role, but the effect on the blood pressure is rather too small, and it's very unlikely that this is the only explanation for its observed benefit. There are both high levels of uric acid and weight reduction, and both are known to cause renal problems. We don't know whether these factors are at play. So significance of the evidence that we have till now. The results suggest that SGLT2 inhibitors might improve renal outcomes and slow the progression of kidney disease. That is what the data we have. However, care should be taken when making assumptions, primarily because the follow-up time in both the EMPA-REG outcome trial and the CANVAS program does not allow any conclusion regarding the long-term effect on SGLT2 on kidney function. We do not have that data. On the face of it, it is better, but we have no idea about the long-term data. Although other renal endpoints were investigated in this study, their occurrence was very low, and this does not allow any definitive conclusion. This is regarding the 40% decrease in eGFR and the end-stage renal disease. The numbers are too small to really draw any serious conclusion with it. Again, going forward, regarding the positive findings of albumin-urea reduction, it should be mentioned that that is not considered a good marker of renal function improvement, mostly because it might be linked to the decrease in GFR. Finally, the results are just applicable for a collective of patients with type 2 diabetes with established cardiovascular risk. All these patients had proven cardiovascular risk. What does it mean? They already have significant macro and microvascular disease, and further investigations are needed to conclude that SGLT2 inhibitors tackle cardiovascular and renal mortality in the long term in subjects without this risk. So whether giving a newly diagnosed type 2 diabetic who does not have any of these risk factors, would this help him in preventing cardiovascular and renal complications? We do not know. So to conclude, the class of SGLT2 inhibitors has great potential to improve glycemic control and to reduce cardiovascular mortality as evidenced from these studies. There are encouraging results showing a slower decline in renal function in patients with diabetic nephropathy. There are still a number of open questions, in particular whether the observed effects would apply to patients without a cardiovascular disease. And further efforts such as the CREDENCE trial, that is the canagliflozin and renal endpoints in diabetes with established nephropathy clinical evaluation, that's the CREDENCE study which is likely to come out, will be needed to discern the impact of SGLT2 inhibitors on renal outcomes in individuals with nephropathy in greater detail. Thank you very much, ladies and gentlemen.
Thank you, Dr. Vijay Panikar. Any questions? Anybody has? It's a nice presentation, Dr. Panikar. Can you explain that how soon you get these renal benefits moment your patients start on the canagliflozin, especially patients who have a GFR of more than 60? And if it starts so early, is the mechanism purely hemodynamic, or it's tubular, or both?
See, basically what we have seen is, as soon as you start an SGLT2, first 6 to 13 weeks the eGFR comes down. That could possibly explain the albuminuric difference that you are seeing. To see whether there is any structural changes which takes place, we have no data.
Like doubling of the creatinine. Suppose we have a creatinine to begin with, say, 1.
The doubling of the creatinine is also delayed. So when you look at that age group going into end-stage renal failure, there was data on doubling of creatinine. The doubling time for creatinine is reduced in patients with SGLT2.
So that normally comes in less than 6 months' time.
Yes.
Roughly about that time, the renal effects. There are a lot of animal studies people have seen and did the microscopic work. There's a special mouse model called Akita mouse, which has a large number of SGLT2 receptors in the kidney. So this mouse is picked up for this study of the SGLT2 in a laboratory model. And what they found out that when you do the histopathological structure evaluation, it showed the reduction of fibrosis. And that fibrosis reduction is a very important sign that there is improvement in the histochemical effects also on the liver. So
that has been shown with linagliptin also.
Yes.
Same, identical.
Yeah.
But I didn't know it was shown with SGLT.
Yeah. It's also shown with Akita mouse.
Linagliptin has shown that
the
it can reduce the structural fibrosis in the
So there's a transition in linagliptin. There's a transition of endothelium to mesenchyme.
Yes. So
and
that is
controlled by TGF-alpha.
Yes.
And the TGF-alpha is driven by DPP-4.
Correct.
And if you inhibit the DPP-4, then there's effect. Here it is the structure of the tubules, structure of the glomerulus is improved, and the glomerulosclerosis is prevented. And that's how these patients improve. This is only in the animal model. There is no human data as of now.
There is no human data.
Any other case?
But just to add here,
yes.
DPP-4 also has shown very significant reduction in albuminuria, especially studies in linagliptin. And the Carmelina study and the Carolina study will bring out further details on the renal benefits of DPP-4, which are very similar.
Yes, very. Yeah, question?
So up to what age we can use it? Means, is there any age limit that don't use it beyond 70 or 75, something like that?
Sir, as long as, when you have somebody above 70 and you give an SGLT2, he'll have to go to pee more often. So you'll be troubling him. So from that aspect. But if he's a fit and fine guy, no problem in giving as long as his eGFR is more than 45. eGFR less than 45, because do not use an SGLT2.
Now the longevity is increased and people are fat also. Old people are also very fat. So that's what I'm asking.
Need to be careful when you
Can we put the patients above 70, those who are on?
There is no contraindication.
No, especially patient diuretic therapy, then be careful. There is no drop in the pressure. There is a chance of syncope. With the syncope, they might get fall and fractures. Anyway, these drugs are blamed for the fractures. So frail individual, do not use it. People who are already in high dose diuretic, be careful. And people who have a fluctuating blood pressure, postural hypotension, better be careful. Otherwise, it's okay. Thank you very much, Dr. Vijay Panikar.
Thank you,
excellent
Vijay.
presentation. Thank you very much. Our question.
Yeah.
There's a demand.
Cases of acute kidney injury was reported.
No, come again.
Few cases of acute kidney injury reported with canagliflozin.
These are acute pyelonephritis, severe infections.
Okay.
Not a definite direct injury to the kidney. It was because of the glucose being going, you can get a balanitis, you can get cystitis, you can get pyelonephritis. And there are patients who have had severe pyelonephritis, and I have seen one of my patients whose kidney had to be removed. So that is because of an infection.
He wants to ask a question.
So one
Yeah.
question, really nice lecture. Actually, yesterday there was a lecture by Dr. George Bakris, and he said that ACE inhibitors, ACE and ARBs cannot be used in microalbuminuria because they won't have any beneficial effect and it cannot stop the progression. So, do you think SGLT2 inhibitors will have a role to
No,
play?
but ACE and ARB do not reduce or prevent albuminuria. I don't buy that. They do.
What his lecture he said was that
He was saying yesterday.
macroalbuminuria, the ACE and ARBs would be effective, but in microalbuminuria, the data he showed that it does not inhibit or does not stop the progression towards
He's
macroalbuminuria.
saying there's no data. There's no
There
data.
is no data, but we see it in practice that, see, if ACE and ARB can reduce macroalbuminuria, why not microalbuminuria?
Now, the indication he was saying is that when you have a microalbumic phase, there is no benefit in giving ACE-ARBs.
Okay.
Yeah, there is
And-
evidence to show that there is
No,
a benefit.
but there are studies which have shown that patients who are on ACE or ARB with a well-controlled blood pressure and sugar have a less chance of getting albuminuria.
That is controlling sugar.
That is, yeah, so by controlling the other three aspects, that's the lipids, the
Sugar,
blood pressure, and the
lipids.
sugars, yeah. The progression can be controlled. But my question was that can we use the SGLT2 inhibitors can also prevent the progression of microalbuminuria to macroalbuminuria?
See, as a treatment of microalbuminuria only, I would not use an SGLT2. As a treatment of diabetes, yes. And if I have to just reduce, and assuming that I accept that ACE and ARB will not affect the microalbuminuria, just because there is no data, I don't buy that. But DPP4 does it. DPP4 can reduce the microalbuminuria. That would be a better drug, simpler drug than an SGLT2. Because if you see in practice, the maximum dropouts are patients who are on SGLT2. When you compare it with the DPP4 and SGLT2, the maximum number of dropouts of patients are those who are on SGLT2. So if I have a choice to use only in terms of microalbuminuria, I would prefer a DPP4.
Okay, thank you, sir.
Thank you, Dr. Panikar.
Thank
It was an
you.
excellent presentation.